Good morning. My name is Joy Hoskins. I'm the Division Director for the Division of Women's Health. Thank you for joining us today for our Division of Women's Health Financial and Policy Training. Today's training, I should say, for May 18th will be archived. And so if there are individuals from your agency who were unable to participate in today's live training, we certainly will record this and let you all know when the archived version webcast is available so they can view this information. The topics that we're going to cover today include the local health department indirect procedures and that policy piece, which is such a critical component, particularly with all programs, but particularly with our family planning program. And we receive a lot of questions about the indirect policy. And so Melissa Freeman, our partner from the Division of Administration and Financial Management. There's somebody that has their mic open. Thank you. So Melissa Freeman from the Division of Administration and Financial Management, who is the internal policy analyst, will be providing that overview and that information for us today. Rebel Baker and Silveram Murata will be speaking about family.
It's just that over there. It won't work. It's working here.
Marshall County, your mic is on.
Oh, sorry.
Thank you. So Rebel and Ron will be talking about the family planning reimbursement piece. There won't be any information that's new compared to the previous presentations that we've shared at the CADA meeting, at the nurse leader meeting, at the plan and budget meeting, but this will be another opportunity for that training to be shared with local health department partners to see if there's any questions that you all may have for today's meeting. Melody Stafford and Rom will be up again to talk about the Kentucky Women's Cancer Screening Program policies and reimbursements. So that will be a good review and update for those of you all who may have not been able to participate in previous trainings. And they'll talk about the reimbursement piece and the ACH 58. Then lastly, Benita Decker and Tiffany Logan, they did not have a PowerPoint presentation, but they're going to be speaking to you all about ADLAS and health funding and opportunities within that program. So with that, I'll go ahead and if there's any questions, you all please feel free to ask those within, of the speaker. We hope this will be an interactive presentation and a time to learn a lot of great information and share and get feedback from you all. So Melissa, if you'd like to come on up, we'll go ahead and looks like your presentation is already loaded and ready to go. So thanks again for joining us. Here we go, Melissa.
Good morning. As Joy said, my name is Melissa Freeman, and I work in the local health budget section, and I work directly with the financial people and the directors of the health department with their budgets and so forth. What I'm going to talk to you all today about is the indirect procedures. Somebody have a mic on?
Could everybody make sure that their mics are muted? I believe there's some people that have called in by telephone. You can use the mute button on your phone. We would appreciate it. Thank you.
But we're going to talk a little bit about the local health department indirect procedures. There are two areas of indirects identified, not in all programs, but in all the clinical programs, which would affect family planning and breast and cervical cancer, which are two of the biggest women's health programs. There are indirect expenditures, which there are 7 different pools for those indirects, and then there's a resource.
Except for the first stuff.
Someone has their mic on. Can you please mute it? Thank you. There are 7 indirect cost pools, and then there are the 2 pools for the resource-based allocations. The 7 indirect cost pools are $897 space, $898 departmental, $899 clinic, $900, which is other medical, $901 environmental, $902, which is other projects, and $903, which is home health. Not all agencies use all of these indirect cost pools, but the main ones health departments use are space, departmental, clinic. Some will use the other medical, environmental. Now, the resource-based cost pools are $700 and $718. So when you're doing your clinical services and you're PEFing for those services, you're coding your time to cost center $700 and $718. And then at the end of each month, all the CPTs you entered off your PEFs are calculated weights, and based upon the percentage of weights that for each one of the programs, whether it's dental, family planning, breast and cervical cancer, maternity, WIC, pediatrics, adult services, STDs, TB, or any of them, it calculates your weights and then spreads based on that. And we're going to talk a little bit more about that from 700 to 718, depending on whether it's lab or regular clinical services. I have done for family planning, for FY14, I did a year-to-date financial report to show you, kind of explain what your financial report looks like. As you can see, I'm hoping you all can see this. I can make it bigger. At the top of financials, you will see the revenue. You can see all the sources of revenue that go into. And I chose family planning because it's one of the bigger programs in women's health, and it encompasses all avenues. But you have, your state money for family planning. There was some MCH block grant money that was allocated for family planning. You got your Title 10 family planning money that you can see, $4.3 million that Women's Health allocates to the health departments for the year. There's the local health tax money, which is the money that you all contribute to family planning. Donations. You got Medicare and Medicaid, which are also payers for family planning. And then you've got what your patients pay, whether they're paying through insurance or they're paying through self-pay. And then the different other revenues. Then you have expenditures, which is where the indirects come from. But there are direct expenditures. You can see that there is salary directly coded to family planning or breast and cervical cancer or abstinence, whichever program it may be. You also have office operating expenditures because, you got expenses to operate the program. If there's travel, there could be either travel expenditures or automotive expenditures. If you're buying some, then there should be capital. Alright, now to get into the indirects. This orange part that I've highlighted down here, these are those 7 cost pools. These are your departmental, and as you can see for family planning, there's only departmental, medical, and space. The departmental is coming from cost center 898, and statewide there's only $50,000 going there. That's because there's not a lot of salary coded directly to family planning. All of the time spent mainly in family planning is coded to cost center 700 and or 718. So you can tell that there's not a lot of actual indirects going into family planning because it's based upon RVRVs is where the biggest amount of expense that's associated with family planning is coming from. There's a little bit of medical indirect. That is spread based upon salary as well. So if there's not a lot of salary, then, and each agency is going to be different. You can have, for example, Lake Cumberland District Health Department, which is one of our biggest districts, who has a bigger cost pool, could have, a different indirect percentage rate than Bracken County Health Department, that's a tiny health department, and has a smaller, cost pool. So Lake Cumberland has more places to spread to, whereas Bracken County might have fewer places to spread to. So it's based upon the size of your agency and the size of your cost pools on what percentage of indirects you're actually going to have in that for departmental and medical. Now, space indirect is allocated based upon the amount of space that you have allocated for family planning. Space is also allocated to 700. So for the clinic portion of doing family planning, you would put that space into 700. But if there's, the community portion of family planning or, follow-up portion of family planning that they might be doing, you need to allocate a little bit of space for family planning because you got salary directly coded to there. And that's the rule of thumb. If you have salary coded to a program, then you need to have space allocated to that program. But as you can see, statewide, $10,000, so that's not a lot when you're talking about a $15 million program. The biggest place that there are indirects, as you can say, coded, is based upon services. When you are doing your actual clinical services and you are PEFing those services and those PEFs are being entered into the system, every time a CPT is entered into the system, it gets a weight. It gets what we call a resource-based relative value. That weight is assigned to those CPTs. Those CPTs are then assigned to a cost center, which in this case would be 802 family planning. Those weights are added up and are assigned a percentage. I have done the statewide RVRV report, and I've highlighted in purple the portion for family planning. As you can see, the RVRV, every health department gets this RVRV report. It's report 001. It will show you what percentage of your 700 and 718 is being allocated to each one of your programs. It is considered indirect. However, it's based upon the services that you perform in your agency and what percentage of those services that you perform are being allocated to family planning. So in this case, it's broken down between preventive medical, preventive counseling, problem medical, and problem counseling. Made it bigger. Okay. So as you can see, for statewide, there were 9.8692% for preventive medical, which is part of the biggest for family planning, is being allocated to family planning. So if you go over to your financials, you see that there's $7 million for preventive medical based upon the weighted allocation. And so forth. The same thing for, there is no preventive counseling, but there is problem medical. And the CPTs and the ICD-9s drive whether it's preventive or problem. And you got 4.4 million. So if you go over to your financials, you can see that there is 4.4 million allocated for problem medical services. And then you have your labs, which is coming from 718. And, there is a big percentage of labs going to family planning because your biggest programs that do that do labs are, is family planning and WIC, and then I think STD. Yeah. So you do have 23% of statewide of your lab services, those expenses going to, and these are statewide averages. If you want to know what percentage is going to your health department, you need to look at your report 001, and that will tell you how it's working in the system. But you can see 1.3 million has been calculated there based upon the percentages, and we have 1.3 million on our statewide revenue and expense report. That's kind of like a rundown of how the RVRVs are done and the indirects are spread. Indirects, The ones in the orange are easy. They're either done by salary or the percent square footage. The rest of it is done by weight, so it could vary each month what percentage is going. Because if you do a lot of family planning services in February and then in March you don't do any, then that's going to change your percentages. But it does go back year to date. The report 001 is a year to date report. So if you're a health department that's not, you'd use CDP as your financials, then you need to spread, because we send those reports to you and you all have to use that report to spread from 700 to 718. So you need to respread that every month because that percentage will change because it's a year to date number. Are there any questions? Okay.
Could you speak, thank you, Melissa, could you speak a little bit about the report 0001 and the data elements that are in that report, and what would the best way be to use that report?
Well, you really don't have to use the report 001. This is what the report 001 looks like, except it doesn't have, I added the expense column.
Okay.
Because I wanted to to show the correlation between the two. But this is what it looks like normally. Obviously, it's not in Excel, it's just a report. I transferred everything to Excel to make it easier, and so I could add that expense column. But what it shows you is for each one of these categories, and you know, it'll show you based upon, these are my weights. So my CPTs were weighted. This is my total weight for preventive medical. That were allocated for each one of these cost centers. And then this is your total weights for the whole, for all 700. And it takes a percentage of what this 71,000 is for like adult services. And 7.3% of this is going to go to preventive medical for adult services. And it does that for every program. And then you have another pool over here for labs. So statewide, there was 2.6 million weights for lab services. And then those were allocated, nobody can see me pointing, sorry. Those were allocated to each one of the programs based upon the percentage of weights of the total. And so each month, CDP is the one that runs this report for you all, because all health departments use CDP for the PSRS, and they can calculate this for you. CDPs is done behind the scenes automatically. It takes these numbers and it takes whatever the expense is in cost center 718, and it's going to spread 23.9174% of what is in cost center 718 to family planning. And it does that for every category. And that's why I said earlier, you really need, if you're not a CDP user, then you really need to make sure that whoever is helping you with your financials is using that as a year-to-date report and not using it as a monthly report, because it is done year-to-date.
So Melissa, this is an additional funding. Is it between 718 and 700?
This is expenditures.
It's expenditures, but it's not reimbursement from those expenditures. Like there's not like state general funds or whatever in 700 or 718.
No, there is no funding in 700 and 718. At the end of each month, if you looked at your financials, 700 and 718 would be a zero. There's nothing, and that would be the same for the 7 other cost pools of indirects. At the end of each month, the balance in those cost centers is zero, because that's where you code your expenses, and then it's those expenses at the end of each month spread out to the other programs to be part of their expenditures.
Melissa, this is Kayla at Penny Roll, and I don't know if other people watching ITV are having a trouble seeing the spreadsheets, but is there any way we can get a copy of that sent out to us to look at?
I will see what I can do in a little bit. I can't do it right now, obviously, but I mean,
That's fine, thank you.
Isn't it a CDP report?
It is a CDP report. I mean, you can't see the statewide numbers, but it's the equivalent of your report 001 that you get each month on PSRS. So every health department has access to this report. It's just,
Okay, it's just hard following you when we're not able to see it right now, so,
yeah.
thank you.
But if you take your report 001 for, say, April, you can tie it back to your 802 family planning and see where those numbers came from your revenue and expense report.
And so part of the discussion, Melissa, with our local health department directors and nurse leaders and financial points of contact is since we're revamping the reimbursement methodology for family planning, those funds can only be used for direct costs. And so what we were, so that's started a whole additional conversation that was going on at the same time about indirect costs.
Right.
So if I was a local health department director or financial manager, how would I be able to, or from a monitoring and overview perspective, what types of adjustments or realignments or expenditure changes, that type of thing, what could we do for the indirect piece that would have a positive impact on their overall expenditures for 802? Or are there any, or is there anything?
Well, I mean, as far as the main indirects, you only got $68,000 statewide that you're saying the money can't cover. These are based upon services. So as long as their health departments are PEFing and entering them into the PSRS correctly, if they're doing correct coding, then these expenditures down here are in addition to the direct expenses that are actually being coded to 802, because these are family planning expenditures as well.
So essentially, by going to fee for service as compared to the way that we're reimbursing this year, now they will be reimbursed for everything in the purple. Through,
Not necessarily.
Okay.
I can't exactly say that, because if they come in there for a family planning service and they do a flu shot or they do something else that's for another program, then those are going to go to family planning, because all the CPTs for that service follow the initial visit.
right.
So that's why when health departments get their year-to-date services, mainly you find a lot of flu shots going everywhere.
Right.
Because if they come in to do something, the nurse could say, hey, do you want a flu shot? Whatever they came in for, that flu shot's going to go with them wherever. And that happens with other services, you can tell.
So they'll get reimbursed for what's in the purple that's on the approved CPT code list.
Correct.
Okay.
But if there's anything outside of that, they will not get reimbursed for it. And they're not getting reimbursed for these direct expenditures.
Okay.
Because those are not tied to CPT.
Okay.
That makes sense.
So just in summary, would you mind just to repeat that? I think that's a really important point that we, weren't aware of from our level of expertise and understanding. So that would be real helpful, perhaps, for the field. If you could repeat that.
Yeah. Since family planning is going to a fee-for-service reimbursement, they're mainly only going to be reimbursing you for the services that you enter into the PSRS system, which is the expenses that are in 700 and that are being spread to 802 based upon the RVRVs. So, I mean, it's not going to be an expense. It's never been an expense-based reimbursement. You've received an allocation and your expenditures always exceeded that allocation, so you got paid, reimbursed your full allocation. So the difference is you're going to be able to tie the services to your payment and realize that, because, and family planning is not the only payer. I mean, DPH is not the only payer for women's health. You have the MCOs that are paying you as well. And I think this year you're going to have some of your breast and cervical cancer is going to cover some of those services as well, and I'm sure that's going to be discussed later today. So you've got Title X covering it, you've got cancer covering it, and you've got the MCOs covering as well. But as I pointed out before, those direct expenses, that's why you need to make sure you're coding properly. Make sure, you know, when you're doing a clinical service that your nurses are coding their time to 700 properly. It's all, with all of these, the resource-based relative value, it's all about coding, and with the indirects, it's all about coding. If you're coding properly, then your spreads should be spreading properly. If you're not coding properly, if your nurses aren't coding properly, if your support staff's not coding properly, then that can skew your allocation spread.
So for fiscal year 16, would you anticipate, Melissa, that those weighted categories that number will shift since we're changing the reimbursement methodology, or they'll basically still be the same?
As long as they're doing the same volume of services, that won't change at all.
Okay.
Yeah, because the reimbursement has nothing to do with that portion of it, because you're taking
the expense piece.
Right, it has nothing to do with the expense piece, because you're taking a list of CPTs and saying, I'm paying this X amount of money for this CPT, so it's totally on two different. So, I mean, if their services go down or go up, then that will change. But that's the only thing that will change that.
Is reimbursement going to be based upon service date or date it's entered into the system?
I'm assuming that it's going to be based upon the service date beginning July 1st. So, I mean, and that's a big thing too. If you're not caught up on your PES, then that, you know, skews your reimbursement too. If you're not caught up on entering in your PES, then you think you've done all these services, but you haven't. So, I mean, Women's Health will have to say if they're only going to look at the services that were keyed in that month, or if they're going to look at a year to date and back out. So that would be for them, yeah. But I mean, the thing is, stay caught up on your PES, so you're making sure that you're being reimbursed timely. That's my advice.
and I think that's a point well taken, Melissa, in that before, when we reimburse local health departments according to a grant allocation process, they would receive 1/12 of their allocation each month, and so there wasn't necessarily the incentive or the impetus for the PEPs,
right,
specifically for family planning, to be entered in a timely fashion. That is not going to be the case, effective July 1st. That timeliness and accuracy and completeness of the PEPs will be even more so important for the family planning program now that we'll be moving to the fee-for-service.
Yeah, and I mean, that's going to be the case for, everything, because she's going to pull services for 802 and whatever services are keyed into 802. So if you are doing a family planning service and it doesn't hit 802, then you might not get reimbursed for it. I'm assuming it's the way you're pulling it, because that's the way you do it for breast and cervical cancer. So, I mean, it's all about coding. You got to make sure that your nurses are coding the PES correctly. You got to make sure that your support staff's entering in those PES correctly, because that's the driving force when you go to a fee-for-service reimbursement. Does anybody else have any questions? And as I said, you can get this report off the e-reports. It's report 001. It comes out every month. And then, of course, your financials would be on the 116.
Melissa, I have one more question.
Okay.
When you said that the other services would follow the family planning visit, Is that following the reason for the visit for that date of service, or is it the primary ICD-9
It's
code?
the
or what?
primary ICD-9 code,
Okay.
is the way I
So-
understand it, yes.
So that's how we would define that. It would follow the family planning, the V25 for if that was in the primary position.
Yeah. It follows your primary, what you're primarily in there for is the way I understand it. Everything that, all the other CPTs follow that one.
Gotcha. Thank you.
If nobody else has any questions,
Give me a minute.
you get to talk to Rebel now.
Thank you, Melissa.
Oh, you're very welcome.
Just pay me, Joy, don't worry about it.
Ready? Good morning. I am Rebel Baker, the Assistant Director with the Division of Women's Health, and I'm here today with Sivaram Maratha. He is the data manager with the Kentucky Women's Cancer Screening Program, but he has been instrumental in helping us revise the reimbursement policy and procedures for family planning. So he's also going to be a point of contact for us today and moving forward. As Joy had mentioned earlier, the information that I'm going to be sharing with you isn't really new information. It's information that we've shared and presented at CADA and at a few other locations, but this is an opportunity for anyone who hasn't had a chance to see those presentations before to ask questions and have a conversation as we're moving forward, because this is something big that we're doing this year. So we're going to move forward with our presentation. As Joy had said, effective for fiscal year 16, starting July 1, the Family Planning Program, Cost Center 802, will be reimbursed based on a fee-for-service model. The reimbursements that we are going to be making with the Title X funds are going to be on the following. Number one, we will be reimbursing for uninsured clients, which includes undocumented clients. Number two, we're going to reimburse where there is a no home contact is an issue regardless of the age or payer source. Balance of sliding scale fees for clients between 100 and 250% of the annual federal poverty guidelines. Title X will reimburse the balance up to the reimbursement rate. So, for example, if you have someone coming in on the sliding fee scale between 100 and 250%, if that person slides and the fee for that service is $100 and they're going to slide to $50, then Title X will cover the other $50. We have developed a CPT code list that was sent to everyone this morning. I hope everyone got that. This is currently a draft list, and the way we come up with the codes on this list, we have reviewed the CCSG, the AR, the PEFs, family planning contracts, local health department plans, and we also compared that to the KWCSP approved code list. We have included office visits, contraceptive methods, and lab codes on the list. Most of these codes were already included in the Medicaid preventative fee schedule, and that's the amounts that we've used. For those codes that were not included on the preventative fee schedule, we have used the Medicaid physician fee schedule. We have included the W codes and the DPH encounter codes, and counseling is also included on the list as well. We will be reimbursing the local health departments at 90% of the preventative Medicaid fee schedule. So the rates that you will see on your CPT code list are for 90% of the rate. And I have asked that, because this is still in draft form, we feel like the list is pretty comprehensive, but if you can look over the form, because this still is in draft, we are open. If there's codes that we have inadvertently omitted on here, please contact myself or Joy or Rom and let us know. We want to make sure that we have included everything on here that you're currently doing that falls within the guidelines of what we can reimburse for. Just to make a note, at this time, the STD codes are not on the list. That will be considered as we move through the year to see what's actually going into the 802 family planning. As Melissa mentioned earlier, it's going to be imperative this year that we do correct coding and timely coding to make sure that we're able to get you reimbursed. Back to the 90% of the preventative Medicaid rate, the reason we have come up with the 90% is because we wanted there to be an opportunity for that 10% match that the family planning program is required to meet. So we've talked about who we will cover. Let's talk about who you need to collect reimbursements from in order to get payment for the other patients that are coming into your clinic. You will need to collect reimbursements from Medicare, Medicaid, the MCOs, from private health insurance, sliding scale fees, so you'll need to collect the fees from the patient that fall between 100 and 250% of the annual federal poverty guideline, and you'll also need to collect the fees for those patients coming in that are 250% and above the annual federal poverty guideline. Those will be full pay from the client. Title X funds will not be used to cover clients over 250% of the federal poverty guideline. Do you want to add anything?
No, I think yes, 250% up to 200.
Okay. Family planning reimbursements, again, will be based on 90% of the preventative health fee schedule. This assures that the required federal family planning program 10% match is met by the health departments. Federal reimbursement rates are subject to change annually at a minimum. So the rates that are on your CPT code list are changed annually by CMS, and that's usually done around December, the January timeframe. So as those rates are changed, we will update and revise the CPT code list, and we will send that out to all the local health departments at that time. So you'll get an annual updated list every year around December or January. Is that usually, Melissa, when that comes out?
They change those in January, so it's probably going to be around February.
Okay.
We'll be able to update them.
Melissa says that the new list comes out in January, so it's probably going to be closer to February before the new list comes out. Reimbursements will be processed on the 10th of each month based on CPT codes entered by the local health department. So we're going to go in the 10th of each month and we're going to look at what codes have been entered into 802. And that will be what the reimbursement for that month will be based on. So anything that is coded in after the 10th of the month will be reimbursed for the following month. Reimbursements will be made up to the fiscal year allocation for each local health department. Reimbursements will also be made regardless of a client's residency, and that is not just their country residency or their county residency. And we have referenced 42 CFR 59.5 that can talk about that. There's been a lot of discussion about residency, and we wanted to reiterate that and let you know that we will be reimbursing regardless of the client's residency. Reimbursements will be made for services entered into the PSRS system up to 12 months from the date of service performed, and that was just asked while Melissa was up here. So the policy is going to be that we're going to reimburse up to 12 months from the date of service. Again, it's important to get those codes entered in a timely manner so we can reimburse you for what you've done. HAPS and HPV code testing. I'm going to let Ron talk about this for a second.
What we would do is we would cover this reimbursements and the HAPS and HPV testing in the next presentation with family planning, if that's okay.
Right, that's
Okay.
fine.
Yeah.
So I'll just touch on it here. As you will notice when you look at the CPT code list, KWCSP, PAPS, and HPV is not on your list as an approved family planning code. The reason for that is because KWCSP funding will be reimbursing you from the 802 cost center for women ages 21 to 64 per the CCSG guidelines, and Ron's going to go, and Melody will go into further detail during their presentation next. This is going to be an additional revenue stream that's going to go into Family Planning 802, which is going to increase your total allocation for 802. Now you will have KWCSP, CDC federal funding. You're going to have Title 10 federal funding, as well as some folic acid money. So that will assist you with your total 802 allocation. Again, just to emphasize, the local health departments must enter these procedures into CDP PSRS system in order to get reimbursed. And if there's any questions with billing and coding, we've got a note on here with a phone number and extension for the local health operation branch. And then we also have contact information for Joy, myself, and Ron. This is a new endeavor, and we're asking for everyone's patience as we move forward in the next fiscal year. We're very excited. We're hoping that by moving to fee-for-service, that this is going to help you better align what you are doing with how you're getting reimbursed. So I'm going to expect that there's going to be some hiccups as we move along the way, but we are very open to your comments and suggestions on how we can better align what you're actually doing in the health department to what we can reimburse you for. So that's the presentation that we have today. Are there any questions out there on what we've discussed?
This is Rania from Fayette County Health Department. I have a couple questions.
Hey, Rania. How are you?
I'm good. They're pretty specific to Fayette County, so if you want to answer them offline, just let me know. But one of the questions I have is, how will we get reimbursed for services that we refer off-site for, like the tubules, sterilizations, things like that? In other words, we wouldn't be coding those here because they're not performed on-site.
Does anybody want?
Yeah, hi, Rania.
Hi.
This is Joy. The way that I would recommend that you reimburse for those services is in your contract. You would have, I'm assuming, a reimbursement rate for those services. I would recommend that you align those reimbursement rates with the rates that the family planning program is going to reimburse you for, and reimburse your subcontractors at those rates.
Yes, but how would we trigger reimbursement from the state to us for those procedures?
You will be entering the data. Rohania, this is Ram. You will be entering the data just like in KWS cancer program. You will be entering the information just like the cancer program, and the program will reimburse you on a monthly basis to you all.
So we need to enter them as an off-site encounter, it sounds like.
An off-site encounter?
Yes.
Okay, that's something we'd have to start doing here, because we wouldn't typically have done it that way. I have a second question too.
Okay.
As far as the Kentucky Women's Cancer Screening Programs to support the PAPS and the Family Planning Program, how's that going to work at Fayette County Health Department? And again, this may be something you want to get with me offline.
Yeah, we'll talk about.
Yeah, we can talk about that at a later date.
With you offline. We'll talk with you offline on that, Roanya.
Okay, sounds good. Thanks.
You're welcome. Are there any other questions about the family planning reimbursement?
Hi, yeah, this is Denise from Hopkins County. So
Hey,
what
Denise.
you're saying is, hi, good morning. You're saying our 10% is going to be taken off the top of the CPT, so we will not be getting billed for that 10% family planning on our Medicaid match. Am I correct?
That's correct. That's correct.
Thank you. Okay.
No, not
Medicaid match. But not with Medicaid, just for family planning.
Yeah.
The 10% is only for DPH's reimbursement. We're not taking 10% off of your Medicaid reimbursement.
Were you able to hear what Melissa said?
What I'm saying is, if 10% is taken off of each CPT code, then we won't turn around and be billed the 10% match when we pay our match. So family planning is prepaid. Am I correct?
No, that is not correct. The 10% that family planning is taking off is because they are required to pay the federal government match based upon the dollars that they receive for the Title X money. So the anticipation is that they only pay you 90% for you doing that service, then you're gonna have to put in money to cover the rest of that, which they use as their match to the federal government, because they have to report every quarter. I have to give them a report showing them all the revenue, that is used, and they are required from the federal government to put up a match to receive those family planning dollars.
Hey,
It's a different match.
Denise, this is
So we
Joy.
pay, so basically we're paying 20%, and I thought we were getting down to the 10%. I'm not understanding that.
Denise, this is Joy. The family planning dollars are for individuals who do not have Medicaid, Medicare, or you will be reimbursed for by the MCOs.
Okay.
So it's a different population. Now our
Yes.
Title X funds are going to be focused on the uninsured
Right.
and the no home contacts.
So we're paying a match on that too. Okay, that makes sense then.
You're only paying a match on your uninsured with the family planning clients that we're
Okay.
talking about, that we're funding you. Now, remember that population statewide is about 50-50. You will still be billed for the Medicaid match, the 10%, for those individuals who have Medicaid. But that's a whole different population than the ones we're talking about that are being served through Title X.
Okay, so just because they're the V25s, we'll just pay the match on them, but, let's see. Okay, I think,
Denise, this 10% is because the state is required to pay 10% on the family planning grant that we're obtaining. So the local health departments, by having this, is paying the 10% for the state to receive this grant.
okay. All right, thank you.
Does that make sense, Denise?
Yes.
Okay.
You can't say it's paying and it's not paying. The program is expending 10% additional money than you're reimbursing.
Okay. Are there any additional questions?
This is Marcia Hodge from Garrett County.
Hi, Marcia.
Couldn't, rather than taking the extra 10% off, doesn't our local dollars we have to put into this program, doesn't that count towards our match? I mean, we're already putting in, I think the things that we're putting in as much money in local dollars as we're actually getting, so why wouldn't that count as the match and we get 100%?
The match, Marcia, this is Joy. The match, we have to be able to assure the Office of Population Affairs that 10% match is across the board with all of our sub-delegates, all of our local health departments. And I can share with you that today there are some local health departments who are not putting in local tax dollars to support the family planning program. So we as a state agency need to be able to assure across the board that all of our local health departments are meeting that match requirement. Now, with that being said, we hope our goal is to, with the fee-for-service, to be able to target and focus the Title X funding on the uninsured clients, and then with local health departments billing Medicaid and other third-party payers, we hope that the goal is to minimize the amount that local health departments are paying for the family planning program out of their local tax dollars. So today, as we look at it, as we look at the revenue and expense statements, I cannot tell the federal government, that all of our local health departments are meeting their match requirements. And so we have to be able to do that from a grantee perspective to our funding agency. And hopefully the amount that local health departments pay out of their local tax dollars will be minimized.
One more question, has it ever been determined that going to this fee-for-service, when we run out of money, if we have expended through fee-for-service up to our allocation, what happens next?
At the end of the fiscal year, what we will be able to do, we'll be able to do realignments. So if there are health departments that have not spent up to their allocation, and because they haven't been able to do the services, there will be an opportunity for realignments. Are there any other questions?
This is
Okay.
Melissa. I have
Melissa?
a question
Okay.
from Ballard County.
Uh-huh.
On the approved CPT list, I don't
Yes,
see
ma'am.
chlamydia, gonorrhea, any STD testing.
That's correct. At this time, the STD CPT codes are not on the list. We'll be reevaluating that as we go through the fiscal year and make a determination as we go through the year if we're going to be able to add those at this time.
Okay, so for now, we just won't get reimbursed for those.
Right. There hasn't been a reimbursement for the STD codes anyway. There's no STD funding, so there hasn't been a reimbursement for that anyway.
Okay, thank you.
You're welcome. Is there anything else? Joy?
May I just say that to Marcia's question, the MOAs that DPH signed with each of the local health departments are for the entire fiscal year, July 1st through June 30th. And so if a local health department's allocation does run out, then, and there aren't available funds, I just want to make sure that we're being very transparent and very clear that, and share with you all in the field, that there still will be that expectation to support the program with other revenue streams.
Okay, if you have an opportunity to go back and look at the CPT code list or at any of the PowerPoints, if you have any additional questions, please contact myself or Joy or Rom, and we will pull all of our heads together and see if we can answer your questions. Again, I want to thank you for the opportunity to talk to you about the reimbursement process and your willingness to work with us as we move through the next fiscal year. Up next is going to be Melody Stafford, and she's going to talk to you about the KWCSP screening program, and her and Rom will be up next. Thank you.
Good morning. I hope everybody is well out there. It's good to know you're behind that camera. Rebel said she was excited, and I'm excited too because I'm going to be going on vacation in the next few days. And if you have any questions after this presentation, you need to talk to Rom about it. So we did send out the ACH 58 just before this program, ACH 58 and the reimbursement policy for the Kentucky Women's Cancer Screening Program. So if you don't have copies of that, that is now should be available on the website or on your email. The agenda, we'll start with the agenda, and we're going to cover the reimbursement policy. We're going to also talk about the reimbursement, KWCSP's reimbursement for family planning program, some other things, and we're going to talk about some changes to the ACH 58 form. I'd like to say that the acronym, or NFR, is going to stand for No Federal Reimbursement, and what we will be talking about is the funding that's provided to the Kentucky Women's Cancer Screening Program through CDC's NDCCEDP. So, yeah, you know, what can I say? Okay, starting out with the reimbursement policy, and Ron, you just jump in anytime you want to, okay? Our program eligibility, the program is for females only, and it's for 21 to 64 years of age. For those women at or below 250% of the annual federal poverty guideline, and they should not have any Medicaid, Medicare, or third-party payer. One thing I wanted to bring up is that we are looking at providing some funding for the underinsured. We've been in quite a bit of discussion about that and how we can make that happen. So I just want you to know that there are discussions, and hopefully that will be put into policy before long. But we have to go a few things.
Yeah, slide.
Oh,
Yes.
so that's probably a good idea. Thank you, Benita. You're on top of things, aren't you? Okay, that's what I just got through saying. Ron, you're supposed to tell me that.
Okay, I was about to say that, ma'am.
Okay, so there's what I just said. And there's some more of what I just said.
21 to 64.
Yeah, 21 to 64. We are the payer of last resort, KWCSP is. We do not fund research projects, and we do not fund in-hospital care. Verification of income is not required. However, it's encouraged, and especially if the staff has any thoughts about the income is in excess of what they're reporting, and you certainly, your policy, you can have a policy to verify income for all clinical services, but it is not required for our program. The approved CPT codes, we only reimburse for those procedures listed on the KWCSP approved rate and reimbursement sheet, and the latest version is version 5.0, and you should have received a copy from that earlier this year. We reimburse for CPT codes up to the allowable Medicare Part B rates, and we reimburse up to the local health department's allocations. Now again, similar to the family planning programs policy, we can, if a local health department exceeds their allocation, there's usually some health departments that may not have been able to spend all of their allocations, and we can do a realignment. That version 5.0 went in effect April the 15th. Reimbursement for office visits, surgical consults should be billed through the standard new patient office visit codes, and of course the type and duration of the office visit should be appropriate to the levels of care necessary for accomplishing their screening and diagnostic follow-up with the program. As we look at reimbursement for cervical cancer, we want to reiterate that the HPV DNA testing is a reimbursable procedure for women 21 to 29 years of age if used as a follow-up to an abnormal Pap result. For women 30 to 64 years of age who meet specific clinical criteria, co-testing is offered and should be offered, but it's not reimbursable as a primary screening in these women. We reimburse for high-risk HPV DNA panel only, and we reimburse for the Cervista HPV HR at the same rate that we would the Digene hybrid Capture 2 HPV DNA assay. There is no federal funding reimbursement for low-risk genotypes of HPV, and sorry about those asterisks, they're on there by mistake, or certain genotyping of the Cervista HPV 1618. As per the clinical guidelines, 21 to 31 years of age, recommendations are a Pap test every 3 years or more frequently if the physician deems necessary. And of course, we always, as nurses, want to follow what the physicians order us to do. The 30 to 64 years of age, a Pap testing alone every 3 years, or they can do co-testing, which is HPV and the Pap, every 5 years. And of course, these are for normal situations. The high-risk women, you can do annually. And of course, we know that co-testing means the HPV and the Pap test done together. We do not reimburse for screening in women with hysterectomies, and we will do Pap tests for women who have had a supracervical hysterectomy. Routine cervical cancer screenings for women with a history of cervical neoplasia or in situ disease, we can do that for 20 years post-treatment. And we can screen indefinitely for women with a history of cervical cancer. Want to add anything?
No, go ahead.
Cervical, if someone comes in and they don't know why they had a hysterectomy, we can do screenings for those that they don't know or is unknown. There is no federal funding for treatment services. Of course, we know that we have the VCCTP program, the treatment program, and they need to be referred if treatment is needed. And there's no federal reimbursement for LEAPs or conizations when used as a treatment procedure. If they're used as a diagnostic procedure, we certainly can reimburse for those. And we will reimburse for liquid-based cervical cytology, other automated technologies approved by FDA for primary screening. Let's see if I had anything else. I've got that later. There is no federal funding for automated technologies when they are used as a secondary assessment of Pap testing for quality assurance purposes. And we will reimburse $100 for each woman reported on your ACH 58 data collection form as rarely or never screened for cervical cancer. So be sure to not forget that and ask those women when was the last time that they had been screened. We will also reimburse for women for an initial physical exam to see if the woman actually has a cervix. Reimbursement for breast cancer screening. Of course, we do screening mammograms. We reimburse for women 40 years and above. We do not have federal funding reimbursement for screening mammograms for asymptomatic women under the age of 40. We also do not have the federal reimbursement for treatment services, as I mentioned before, and for CADs. I do know that there are a lot of physicians that order CADs, but we cannot pay for them according to CDC. They do not, they said that there was no backing for the, what I want to say, for proof of
detection of breast cancer.
Detection of breast cancer. I know that's probably a controversial statement, but that's what CDC tells us.
Melody,
yes, ma'am.
If a woman presented to the local health department who was under 40 years old and she did have a complaint or a symptom, that woman, we would be able to provide services for that woman even though she was under 40.
That's correct. And I appreciate if you did not hear Joy, we do provide funding for women under 40 who has an abnormal clinical breast exam or is coming in with some type of problem, like bleeding from the nipple or anything like that. We certainly will reimburse for diagnostics and screenings for those particular women. But for an asymptomatic or someone that does not present with any symptoms, we do not reimburse. I know we've had some questions on baselines at 35, but at the present time, CDC does not allow us to use our federal funding for that. Okay.
Hi, this is Ava from Madison County.
Hey, Ava.
Hey, I just had a quick question. Because we do our breast exams at 20, what about funding for those young ladies that may have an abnormal?
That may have an abnormal?
Uh-huh.
Below 21 years of age.
Oh, she's 20?
Yes.
Yes, no, we do not. Yeah, we don't provide any funding for women under the age of 21. I'm sorry.
But, you know, the CCSG says that we start at 20, so that's what I was wondering. Are there any other methods of funding for those ladies?
I would say this. If there is a case of that happening, call us. We are working on the CCSG as well as continuing to look at the policies here, reimbursement policies. But the funding for that would not come from CDC, but we certainly would help you find somebody that could take care of that issue. Fair enough?
So, yes, that's fair enough, thank you.
All right, thanks. Any more questions at this time? And I'll keep going. Okay, MRIs. When you may use MRIs when performed in conjunction with a mammogram when a client has a BRCA mutation or first-degree relative who is a BRCA carrier, or a lifetime risk of 20 to 25 or greater is defined by the risk assessment models such as BRCA Pro that are largely dependent on family history. Now, having said that, they do not pay for BRCA, which is the genetic mutation for the risk of having breast cancer. So I know that we have looked at the assessment on the website of BRCA Pro. It would take some time, and once again, we do not pay for that testing. So just to make you aware of that. MRIs can be reimbursed when used to better assess areas of concern for an evaluation of somebody that had a past history of breast cancer. We do not have federal reimbursement for MRIs as a breast cancer screening tool. And there's no funding to assess the extent of disease when somebody has already been diagnosed with breast cancer. And I'd like to reiterate at this time, although there might not be federal funding or reimbursement for these types of things, we have a lot of partners that we can get help from if there's an area of concern, and that even though we're not able to reimburse it with our federal funds, we certainly think of it as a privilege and an honor to help you find somebody that can. Reimbursement for case management, patient navigation. For case management and patient navigation are considered basically the same thing by CDC. When you hear a lot of talk about community health workers, and often a patient navigator is attached to that term, but in our case for KWCSP, the case management and patient navigation is considered the same, and we will pay $100 for any abnormal clinical breast exam, the screening mammograms with those BioRads, and Pap test of those results, and that's per CCSG guidelines or from a physician's recommendation. Now we're coming to the family planning portion of what we will reimburse for, the KWCSP. They'll pay for these CPT codes that I have listed for KWCSP eligible women reported under the 802. Here's the question we're receiving a lot of is about the ACH 58. Eventually, you will need to fill out the ACH 58 for these CPT codes, and this is for optional reimbursement for these procedures. They're retroactive to July the 1st, 2014, and we will pay for those through June the 30th, 2015 and on up, or on after that, I should say, I guess. So people have asked me, should we be coding it already? Well, you're a step ahead if you have, but you can't enter those yet. We are still working on the system to get this, to make it a smoother process, but you would just fill out an ACH 58 on these particular codes. Ron, you want to add anything to that?
No, that's fine. I think once again, it's Joy and Melissa said, data has to be timely, perhaps have to be timely, they have to be complete and accurate. Do not wait for all the bills, try to get them as soon as possible so that we can pay the health departments on a very timely basis. one of the questions that came up earlier during the presentation with Melissa was, how does the reimbursements work? The reimbursements will be year to date. It will be cumulative. So if you have missed any record, that if you forgot to key in any record in the month of July and you key the record in the month of August, we will still pay for it. But do not wait until you get all the bills. Yes.
Okay. And these, it's an optional thing. If you say, well, we don't want to do this, we don't want to fill out the ACH 58 for these reimbursements. Well, you can do that, but money's tight. I think, we'll help you get through it if you're interested in doing it. Yeah, go ahead, Ron.
Yeah.
Oh.
This is Jennifer from Bratton County.
Oh, Jennifer, you better have a good question.
So is this referring to the women that are 21 to 40 that we didn't previously fill it out for?
Yes.
Okay, thank you.
You're welcome. How's the baby?
Wonderful.
Thank you. Anyone else at this time? Okay. Of course, for this particular program, you have to enter those procedures in CDP's, the PSRS system, and ACH 58 forms must be completed. And the program anticipates to reimburse for these tests by July the 30th of 2015. And the deadline to complete these records, these MDE records for these patients is September the 30th, 2015.
I would like to add, Merit, is that CDP will be running the report for all our local health departments, and you will find these reports on 1709 report that ACH 58 form has to be completed for the family planning patient. So you should be receiving a report shortly.
Okay. And then if you look at the ACH 58, which you should have gotten on your email, there's a couple places where there were some additions made, and at the top it just says now that we will pay for 21 to 64. Of course, we all know that's a change. And then down in section E, on both the breast and cervical sides, it talks about, I think it's number 5 on each of them, under the status of breast diagnosis and status of cervical diagnosis. Both of them read, referred to the PCP. And we did this because we want, the only 2 data items that we actually had available to us on the ACH 58 was loss to follow-up and workup refused. And I don't think that was really fair to anyone. Although CDC, we have begged and pleaded for them to add another data point. We're going to do it for ourselves so that we can have a record and show that these people were referred to PCP, they weren't just dropped and lost to follow-up or workup refused. So that's been added, and so you might look at that real carefully on your ACH 58s.
And we did receive CDC permission to do that.
But we want them to put one on theirs.
That's right. But we wanted the ACH 58 for that indicator to be a true reflection of what local health departments were actually doing and the services they're providing to assure that safe handoff to their PCP.
And I know, of course, having been a, Go ahead.
This is Martha at the Floyd County Health Department. I have a question about that section E. So should we be doing the ACH 58 for all 21 to 64 regardless of their insurance? Because usually we refer them to the PCP if they're getting transfer of care to their primary care physician.
Okay. Are you speaking about that they came into your office to get an exam, right?
Yes.
You did the exam, and now you found something abnormal, is that correct?
Uh-huh.
And now you need to refer them to their PCP.
Yes, if they have insurance, we have been doing that.
Yes.
That's hard for me. I still follow some, I shouldn't, but.
It would be me too. But you would mark it, refer to PCP. You know, we've had this issue so much. I was a nurse for 18 years in the clinic, and I feel your pain. We would, certainly CDC likes to know what happens to these women, but we also recognize the amount of time, amount of effort it takes to follow those women after they're referred to the PCP. Whatever you can get, we would be appreciative of, but we also respect your mark there that says referred to PCP.
Okay, so do we need to do the ACH 58 on everybody regardless of their insurance then, because it would reflect in our charting that they've been referred? Because we ordinarily don't refer patients to a primary care physician unless they don't have insurance. We usually try to get them with our contract provider.
So ma'am, you don't have to do that on people just within the scope of what we are, up to 250% of the federal poverty.
No Medicaid.
No Medicaid, no Medicare. Now the issue a lot lately has been you start out that way and then the person gets insurance halfway between.
Okay.
Yeah, I know what you're saying.
Thank you so much.
You're welcome. Thank you for the question. Anyone else? I do want to say on behalf of Ram and I and the Division of Women's Health, we know how hard you work out there. We were able to meet our 11 core performance indicators, which made us all very, very happy for the 18th time. That reflects the work and the quality of work that you guys are doing out in the field. Our appreciation is just, we can't say enough. I know this is a time of change, and I appreciate your patience. Both of these, everything that you've received is in draft form. Again, just like Rebel said, if you have an issue or if you have a question about it, please shoot us off an email. I ask that you also send it either to both to Ram and myself, because like I said, I'll be gone for a little bit, and so we want to make sure that your question gets answered. So send it to both of us, and we'll let you know. But from the bottom of our hearts, we appreciate it, and it's nice to be able to hang in there with you. So thank you again.
Melody?
Yeah.
This is Montgomery County. Back a few slides where you mentioned that the local health department will be reimbursed $100 for each woman reported on the ACH 58 as rarely or never being screened for cervical cancer.
Yes, ma'am.
Where is that at on the ACH 58?
It comes up.
See, if you mark cervix, go ahead.
Yeah, if you mark on Section A where it says cervical screening history date, it says prior PAP test, and then yes or no. If it marks no, then that of course is one never screened. If it's yes and it's been 5 years, then and you do the best you can. They'll say, oh, it was by what month? Well, was it spring, summer, fall, winter, and go from there. But yes, that is correct.
Okay, thank you.
Yes, ma'am. I hope you get a whole bunch of those. So we can get some new women in and get them screened. Anybody else? Oh, yes. And Ron just reminded me, you have, if you don't mind, up to June the 1st. June the 1st to send us back any of your comments on anything we presented today or any of your recommendations.
Melody?
Yeah.
This is Paula from Estill County. Will you finish what you was getting ready to say a while ago about if we have a patient that comes in that has no third-party payer and we enter the stuff, we start the ACH 58, and then before they get finished or whatever, they do get insurance, what do we do about that?
We would love to know what happened to them. Ron, would you want them to go back in and refer to PCP?
Yes, if you can go back and put it as a refer to PCP, and also the date of final diagnosis would be the date when you have referred the patient to the PCP.
Did you hear that? You want me to repeat it?
No, I got it. Thank you.
All right, thank you. Anyone else? Well, if not, I'll pass it on to the adolescent health. Oh, go ahead. Go ahead.
This is Christina from Madison County. We
Yes,
just had
ma'am.
we had a quick question about the ACH 58 forms.
Okay.
So should we be, because you're saying we can get paid for case management even for patients who have Medicaid, correct?
No, it's only up to the 250%. The people that qualify for KWCSP.
Okay, so we are only filling these forms out for patients who do not have insurance and who meet the guidelines for the cancer screening program.
Yes, ma'am.
So if they have Medicaid, we do not fill this form out.
No, ma'am.
Absolutely right, yes, please.
Okay, thank you. That's what we needed to know.
All right, thank you.
Any questions regarding family planning?
Any other questions, family planning?
Reimbursements?
Well, like I said, any,
Okay, so you talk about reimbursement. When I asked earlier, y'all now switch. You're gonna pay reimbursement based upon the data that you get for processed in that month, back for 12 months.
Yes, up to, it will be cumulative and it will be year to date.
Year to date?
Yes.
And you say back to 12 months. Well, if you're doing it based upon when it's processed, that 12 months could be in a different calendar year.
Yes, this will be effective from July 1st onwards and we will move forward.
Next July.
Yes. If it next July, we will still pay for services, from the previous fiscal year.
But at what point are you going to stop paying for that year?
We said up to 1 year, we can pay up to 1 year.
When you say 1 year for the service, that would take you to the second fiscal year.
that's okay.
Yes.
All of your fee-for-service programs cross the fiscal
Yeah.
year. Preventive
No,
Medicaid-
I'm talking about a complete fiscal year. If you go in 12 months.
It's based
you
on
got
the
one
date of
month.
service, not on the day they entered into the.
That's right, that's what I'm asking. What
Yes.
is that date of service cutoff date, not the reporting cutoff date?
It's the date of service cutoff date.
So if they had a service in August the 1st of 2014, 12 months would be August the 1st, 2015.
Yes.
Not the date they entered in the system, it's the date the
They're
service
going to
was,
reimburse based upon the date it's entered.
the date the service was.
If the service was done in August of 2014, or if I enter in 2015, it will be reimbursed for it. After the year.
Need your mic again. You've got audio problems. You may need to send an email your question in, please.
Did that help you at all? Okay, it's from the date of service, we have 12 months.
12 months from the date of service.
Yes, sir.
Okay, it's not going to hit it until it's entered. It now becomes the processing, so you're going to get reimbursed for that process, what was processed that month. Not necessarily what was done that month.
Right, but say if it was done August the 1st and you didn't put it in until January the 1st.
Say it was done May the 30th.
May the 30th?
Yes, and you don't put it in till next May the 30th.
Well, it's not put in, it's been
How about that? Because that's within the 12 months. You said 12 months from the date of service.
the date of service, not when they entered it.
If they wait more than 12 months to enter the service, they're probably not going to pay for it.
Yes.
Yes.
But we
why
can
they put
review
through time.
the report, now you're going to have.
There shouldn't be a reason why a health department waits a whole year to enter in a PEP. PEP should be entered in the month when that service is being done.
I would just let
You got
it's the
clerical problems
statement.
with that.
It's the statement, not when it was entered, it was a statement. You said for 12 months. And that's what I was trying to get is when, it's really not. At some point, and I like all this, you're going to say, we're no longer going to pay for any services for last year.
Oh, I see what you're saying. Yes, it's still the 12 months from the date of service, even if it's into the next year.
So
Doesn't matter.
if it did, you have to find one that was May of the next year, which would be 11 months. That is cross fiscal years,
That's okay, crossing fiscal years is
cross
okay.
grant years.
That's okay.
We do that all the time.
Yeah, that's okay. We will do that. Our program will do that. How about that? And if you'd like to talk to us further, we'll be glad to talk to you further. Any more questions? Once again, thank you all, and
Hey, this
Yes.
is Ava again,
Yes,
from
ma'am.
Madison County. I'm sorry, I'm still.
Oh, you're
learning.
fine. We are too. Go ahead.
The slide that talks about the KWCSP that will pay for the CPT codes, and it lists them, the 88 codes and an 87 code.
Yes,
It
ma'am.
says it says eligible women reported under the 802 Family Planning Program Cost Center up to the local health department's allocation. Is that allocation rate based on the document you mentioned that's the 5.0 version? Or is that, it's not listed on that family planning reimbursement sheet we got today? So
Yes, because those particular codes will pull into the KWCSP. And you're saying, is it allocated through the family planning program or through the KWCSP program?
Yes, ma'am.
Yes, it would be through the KWCSP program, if I'm correct.
What are those
Yeah.
8A codes?
They're
PAP test, 8814 to 88164 under HPV testing.
Yes, and again, I want to reiterate that although you may exceed your allocation, that there will probably be, and I say probably, very general, there will be opportunities to realign from those that aren't used as frequently as maybe some others. So that's about all I can say about that, as Forrest Gump would say.
What I would like to say, I think, is the allocation is from the KWCSP's allocation, which is 813 cost center, and the rates would be from the, as you said, version 5.0.
Tom, would you mind to speak, or Melody, either one of you all, mind to speak about the family planning reimbursements for PAPs and HPV co-testing? Because when Rebel was doing that presentation, we said we do that during your all's time, and so I want to be able to explain to our local health department how that will work.
Okay, well, if you look like, you've got the,
Here's the 10 years.
you go ahead, Ron. You can go ahead.
Reimbursements for family planning program. Just like the cancer screening program, the family planning program would be providing the reimbursements to you all on that, and the data would be processed the 10th of each month. So probably the second week of each month, you should be receiving a detailed report as well as a summary report explaining all the explanation of benefits regarding the CPT codes. The CPT codes would be pulled out from the family planning program's approved CPT code list. And as we discussed earlier, reimbursements would be up to the fiscal year's allocations. You don't have to do anything different. You have to enter the data as you are doing right now. You don't have to make any changes in the system. Just key it in as you're doing. What we would do at the back end is that when we look in the 802 cost center and look at this CPT codes, 8814 to 88164 and all these CPT codes, what the programming at the back end would do is pull these CPT codes based on the eligibility, based on the 802 cost center, and put it into KWCSP's reimbursement file. And the program would do those calculations and will provide you a report each month to let you know that these CPT codes from the KWCSP and the following CPT codes from the family planning program has been reimbursed. So you will be able to identify those PAP tests from KWCSP and the family planning program each month using that report. So once again, you don't have to do anything different. You just key it in as you are using the primary ICD-9 code for the 802 cost center, and we will be doing it at the back end and processing those files.
And the reimbursement for those codes will only be for those women who are KWCSP eligible.
Yes.
Who would present to the local health department for family planning services. And an ACH 58 would need to be completed for those individuals. Is that correct?
That is correct. And to kind of put that in a nutshell, just to reiterate it again, As far as entering it to the system, you're not going to do anything any different because we're going to do it from our end to find those CPT codes that are relevant to the family planning program. The only thing you will have to do different is to fill out an ACH 58 on those women, and I think that's about it. And so, and again, we're a phone call away. Yeah.
When can we start entering those?
We'll let you know. You'll get a big email, and you all can mow together.
And you will be getting a report from CDP on the 1709 report, listing all the cases in the family planning program who had these CPT codes.
So you will be seeing a list that shows which ones, if you haven't been doing any of the ACH 58, which that's fine, but you will be seeing a list come out for there. And remember, we're a phone call away, so just call us and we'll be glad to help you through it. Yeah. Yeah, last year with diagnostic services, we paid more than $700,000 for those women 21 through 39 years of age. So that kind of lets you know how much money is going out. So that's about it.
Melody, this is Melissa at Ballard. I have another question.
Yes, ma'am.
When you're talking about the ACH 58 for those family planning patients, are you referring to normal results as well as abnormal?
Yes.
Yes, now remember, they're just KWCSP eligible patients.
Right.
So no Medicare, no Medicaid, no third-party payer, at or below 250% of the annual poverty guidelines.
Okay, thanks.
You're very welcome. So at this time, I want to thank you and appreciate your attention. But at this time, I'm going to pass it over to the Adolescent Health Coordinator, Benita Decker. Thank you all very much.
Good morning. My part's easy. You all have had enough information in the last hour and a half to chew on, and so all I need to do is make a couple of announcements. Those of you, the 23 health department districts that are PREP awardees, you got your allocation, and that'll be in your budget, and so there's nothing to tell you about that unless you have questions. The abstinence grant, we were allotted some extra money this year, and we needed to upgrade our program and to provide some newer curriculum, so a funding opportunity announcement went out. We have received those applications. They are in review. So if you are a health department that has applied for abstinence funds, those are under review, and in fact, we hope to have that review complete by this week to next week with the approval process, and I hope to let you know by June 1st what your allocation is. If you have any questions about that, just give me an email, shoot me an email, and I'll let you know what's going on. And if we have questions of you as we process those applications, we'll give you a shout. But that's all I have to say about the Adolescent Health Program. Does anybody have any questions? Mine was easy. I didn't have all this stuff you got to learn real new. So now we'll open it up to any additional questions before we close out. As you've chewed on all this information, is there any other questions you have for anyone who's presented? And we'll take those questions right now.
This is Ava from Madison County. When you mentioned PREP, what is that?
PREP is the Personal Responsibility Education Program. We have 23 grantees of grants, and it's like 5th or 6th year. We allocate all that money out to our highest teen birth rate counties to do either a teen outreach program or the Reducing the Risk curriculum. So those people that are on that know who they are, that was just for them. But if you don't get that grant, then you wouldn't have that money.
Is there anything about closing out your fiscal year 15 books for any of your grantees, Benita, that's going to be different or the same or anything
Everything's
like that?
just the same.
Okay.
Nothing's really changed. Abstinence-wise, remember, if you're an abstinence grantee, there's 30 of you out there, 29, 30 of you. Remember that try to spend your money by June 30th, but you have, actually, we're going to have a little overlay this time. Absence grant this time will run in the fiscal year instead of from October 1st until September 30th, which was horrible running through 2 fiscal years. But this first year, some of you who are current absence grantees, you may not spend up all your allocation by June 30th. I'd like you to try to, but if you don't, that's okay. We will reallocate in the new fiscal year whatever you had left over from last year's grant money in addition to your new grant funding. So know that you may have a little extra money in that first 3 months if you haven't spent it all. It'll be a lot easier for you and me both if you can get that spent by June 30th, though. But we'll take care of it if you don't. Any other questions to family planning, to KWCSP, to Rebel, to Melissa Freeman? She's still with us here. Any other questions you all need to ask? Well, I know we've given you a whole lot to think about and to try and process. We are all available for you via phone call and email. And you know, we want, what we're doing is to help you give better services and to do it more fiscally soundly, I guess. And so we thank you for participating. We thank you for putting up with us today, and we hope you have a great rest of the day and rest of the week, and go forth and do good.